introduce Dr. Catriona. Dr. Catriona Henchion. She's the medical director of the Irish Family Planning Association, and she's going to give us a talk today on female genital mutilation, cutting, and an overview with consideration to cervical screening. With us today, we also have panelists. We have the education manager, Dr. Rachel Comer. We have a senior training coordinator, Debbie Ramsbottom, and we have Dr. Sarah Fitzgibbons, who is the primary care advisor to the programme. So I'll let you get started now, Catriona.
Thanks very much, Louise. Okay, so my talk, as Louise said, is female genital mutilation, and particularly with consideration to cervical screening. So I'm going to get started. So female genital mutilation, sorry, just one second, is the partial or total removal of the external female genitalia or any practice that purposely alters or injures the female genital organs when it's being done for non-medical reasons. FGM, as it's called, causes harm, has no health benefits, and as such, it is internationally recognized as a human rights violation of women and girls. It is known by many names, often cutting, closing, and in some places as female circumcision. It's commonly referred to as FGMC, where the C refers to the word cutting, by women's rights activists and healthcare providers, I suppose, because it is quite often referred to as cutting, and that this seems a less sort of pejorative term, but the official WHO approved term is FGM. It's an ancient practice. It predates all contemporary world religions. So even though some people will say that it is being done as part of a religious ceremony, it is not actually advocated in the Quran or any other religious text. It's really a cultural practice that certain communities continue to do. It may be motivated by beliefs about what is considered proper sexual behavior for women, particularly about preserving premarital virginity and marital fidelity. And in some communities, then it is also considered that it's necessary for male sexual pleasure. And these communities will be then ones that will quite often reclose the vagina after childbirth, so that basically the practice is being redone several times. In practicing societies, as I said, it's considered part of the traditions. This causes a lot of social pressure on people to conform and do what everybody else is doing. But most often, parents want their daughters to undergo FGM because they want them to be suitable for marriage, to have a future of respect and well-being, and not to be excluded from their society or stigmatized. FGM is usually performed by a traditional practitioner. That sometimes might also be someone who's a traditional birth attendant, but essentially it's somebody who has no formal training and who has probably been taught to do this by their mother. It will usually be a woman, be very unusual unless it was a medicalized form for it to be a male person doing it. Quite often it will be a relative of the person, and if not an actual relative performing the procedure, then certainly relatives will be involved at the time. Often very crude, unsterilized instruments. So the most kind of common instruments used quite often are the kind of really old-fashioned razor blades that people might remember as the kind of rectangular covered in paper blades. Quite often there might be scissors or something else used as well. And the conditions are not hygienic. This is done usually in somebody's home, or it may be in a hut where, you know, has been set up for that day because it may be done as part of a sort of festival coming of age ceremony. So I suppose it's understandable in some ways that there has been medicalization in many countries and that they feel that this might mitigate some of the adverse effects of the FGM. It is estimated that about 52 million women and girls have undergone FGM by doctors, nurses, or midwives. And while it might reduce such effects as perhaps infection, the WHO has condemned the practice because overall you're still actually removing genitalia and causing harm to women and girls. And if the medical profession becomes involved in it, it really does legitimize it. It makes it much more difficult to really make people believe that it's a harmful practice. They're going to feel that it's beneficial or at the very least harmless. For example, in the Sudan, where it has very, very high FGM prevalence, 87%, and an awful lot of this is type 3, which I will go into in a little bit more detail very shortly. And medicalization is now 3/4 of all cases. Most of these procedures are being performed by midwives. This particular form of FGM has the most severe obstetric complications, but you can understand that it would be difficult for people to believe that their obstetric complications are entirely due to a procedure that was done by a midwife who is, you know, presenting, who's actually with them at the time of delivery. So in terms of prevalence then, there are considered to be more than 200 million women and girls alive who have been cut across Africa, the Middle East and Asia, where the practice is concentrated. More than 4 million girls estimated to be at risk each year, which is projected to increase to about 4.5 million by 2030. It's also being discovered that FGM is happening in lots of places that weren't previously known about. So Colombia, Peru, India, Malaysia, across the Caucasus Mountains and the United Arab Emirates and Saudi Arabia. There's not a lot of statistical evidence on how prevalent it is in a lot of these places. It's also then practiced in diaspora populations in many Western countries. So there are well more than 500,000 women living in Europe who will have had FGM and almost 6,000 in Ireland. This will actually be probably updated and will be a higher number after the next census information is released. A 2015 study, which again now almost 10 years old, that was conducted in Ireland, showed that depending on, the way you evaluated risk, there's anywhere between a few hundred and almost 2,000 girls that could be potentially at risk in Ireland. This just is a global prevalence map. UNICEF compiled these from, data fairly regularly. It's a little bit difficult, it's a very busy map, but I suppose if you just focus on the countries, particularly you can see them mostly in Africa and a little bit over there in Indonesia, where the very dark colors are. So in Eastern Africa, for example, you've got Somalia and Djibouti, and then you've got up into Egypt and Sudan. Those all have prevalences in excess of 85%. And I suppose the main point I would make is that if you have a patient from one of these very high prevalence countries in your practice, it is almost certain that they have had FGM. So rather than it's a possibility, it's almost a certainty. So just to kind of keep that in your head. These maps are easily available. The references should be on them, so anybody should be able to find these. This is just a little bit more simple, and it just gives the names of the countries. And again, the ones with the dark colors are those with prevalences over 85%. 26 countries in Africa and the Middle East now have legislation banning it. These are countries where the practice occurs. And 33 countries that would have migrant populations from those areas, including 10 EU countries, of which Ireland is one. So the Ireland Criminal Justice FGM Act was passed in 2012, which makes it an offence for a person to do or attempt an act of FGM. Consent of the woman or parents shall not be a defence, but it also makes it an offence for a person to remove or attempt to remove a girl or woman from the state where one of the purposes for that removal would be to do FGM. It has a significant penalty attached, including imprisonment. There has only so far been one conviction, and that conviction was overturned on appeal due to issues with translation during the trial. The Children First Act in 2015 also included FGM under physical child abuse. Legislation is very important because it is important for governments to lay down markers to say this is unacceptable and cannot happen here. But obviously, if you're getting a conviction, a child has already been damaged forever. So education is far more important. You need to engage with practicing communities. They need to be educated about the adverse effects of FGM. In most countries, prevalence is decreasing and an increasing number of men and women support ending it. If practicing communities themselves decide to abandon it, it does tend to be eliminated very rapidly from those communities. But this is a huge piece of work. It's almost a village by village approach that has to be taken. So at the moment, there is a certain amount of effort going into health education ads where they will maybe focus on a single message, such as women who have had FGM are more likely to have serious health effects during childbirth. So just to go into the different types, the WHO has classified FGM into four main types. But I suppose it's really important just to, again, come back to the fact that this is a procedure that happens. It's hugely varied from community to community. There is no formal training, so the overlap between different types can be really, really significant. So type 1 would be where removal of the clitoris, or sometimes the prepuce only of the clitoris is removed. And in most types of FGM will involve some partial or total removal of the clitoris. Excision then, type 2, would be removal of the clitoris and labia minora, or possibly labia majora also. And then the last type, type 3, usually has removal of the clitoris and labia, and then the vaginal opening is narrowed by creating a seal by sewing the cut edges of the labia together. A very, very small opening would be left to allow menstrual fluid and urine to escape. But the urethra itself will be actually significantly behind that opening, which can make urination very painful and slow. And then type 4 would be any other procedure. So sometimes you will have piercing or tattooing or burning, sometimes stretching of the labia. And this would be the typical end result of a type 3 FGM, which is, you know, very, very grim. So then in terms of what the health consequences are, the exact incidence of morbidity or mortality is very hard to measure. So that's for various reasons. So firstly, only a small percentage of any complications ever come to the attention of healthcare providers. And this will be because these are quite often remote areas where they have very little access to healthcare, where they're not in the habit of accessing healthcare. It may be particularly in countries where there is law against FGM that they will not access healthcare for fear of legal repercussions. But also there have been very, very few good quality studies done. What we do know is that the immediate complications, pain is really significant. There is generally no pain relief or local anesthetic given. Hemorrhage can be a significant complication. Bleeding is going to happen in every case, but whether or not it's really significant will vary depending on the person doing the procedure, the amount of resistance from the child, the size of the child at the time. Local complications, so swelling and pain from where stitching happens will be really common, and that can quite often lead to at least temporary urinary retention, infection in the area, damage to the urethra, which causes incontinence. And incontinence is a huge, has huge implications because it's a very taboo subject itself. So a woman who is incontinent is likely to have a future of social exclusion. Labial adhesion, so even where the labia are not closed, they may well, if the cut edges aren't stitched properly, they will quite often stick together in various places, which can give you this awful effect of very, very irregular closing or skin bridges. And then depending on the individual and things like nutritional status, hygiene available, there can be very poor healing, so you can get keloid formation sometimes. It's quite typical for women to say that they were very sick for a long time afterwards, that it took a long time for things to settle down. Other infections, so it would be possible for tetanus to occur, depending on, again, the hygiene of the conditions. UTIs would be really common. Septicemia can occur. HIV or hepatitis could potentially be passed, particularly given that many girls are often done on the same day and the same instruments will be used. And then children certainly have had fractures and dislocations simply from struggling to get away. In extreme cases, this can lead to shock, which can in turn lead to death. And shock will be either due to hemorrhage, it can be a later complication due to sepsis, and in some cases is considered to be neurogenic, where it's literally due to the trauma of the pain and the assault. And, you know, I have a clinic there where I, you know, see women who have had FGM, and it's not uncommon for them to have either known somebody who died or somebody died on the same day as they had their FGM, or that to have lost a child from FGM. In terms of kind of long-term complications, menstrual problems, really common. With dysmenorrhea, it can be a little bit difficult to judge because dysmenorrhea obviously is a very common symptom among all women. Hematoculpus, where the menstrual blood simply can't actually pass, is obviously from a complete obstruction, and that would be extremely uncommon and certainly not something that I have seen. But certainly more severe period pain than usual would be common, and it is not always related to closure of the vaginal opening. So it may be due to pelvic floor issues, or it may be due to a sort of a traumatic association with the bleeding. Local vulval problems, very common. So there can be nerve damage leading to areas of the vulva being numb, or again, really painful scar tissue that's very tight and very uncomfortable. Cysts and abscesses can form and then continue to recur, fill and drain. There can be ulceration in the area from attempted sexual activity. Urinary tract problems will be common. So as I said, painful or slow urination is really common. Irritation of the skin caused by urine that's trapped behind the kind of artificial seal that's been made is quite common. And then recurrent UTIs, again, probably because of stasis, and also stones can occur because of stasis. Vaginal problems, so discharge or itch. Itch is a really common symptom, again, probably because there's so much scar tissue that just doesn't have the same stretch or resilience as normal skin. So it's very prone to kind of being itchy or irritated. Bacterial vaginosis and herpes simplex type 2 have been shown to be increased, and gynecological examination or cervical screening may be either very difficult or impossible. Sexual difficulties, really common. Most women who have had FGM will have some sexual difficulties. Excuse me. So painful intercourse, really common. And again, to kind of come back to that point, that may happen even when there is a totally normal opening, normal introital size and shape, and that may be just that there is vaginismus due to the remembered trauma and the fear of being touched in that area. This can lead to people being unable to have sex, so non-consummation of relationships, which can cause in turn sometimes presentations about fertility and presentations, you know, with concern about how to get pregnant, when in fact the reason for the fertility issue is that they're not able to actually have sex. Their physical trauma during attempted sex, and then even where the introitus is normal, there's no vaginismus and they're able to have sex, an awful lot of women will have impaired sexual response, lack of enjoyment, or inability to have orgasms. And that, you know, is related quite often to the removal of the clitoris. In some cases, it may present with anal fissures, hemorrhoids, or fecal incontinence from the only intercourse that's possible, being anal intercourse. Psychological issues would be very common. So post-traumatic stress disorder, where there are flashbacks, nightmares, intrusive dreams, intrusive thoughts, difficulty concentrating, which impacts daily life. Emotional disturbances, so anxiety, depression, low self-esteem, difficulties with body image, fear of, not being normal. All of those things can have huge impacts, can lead to fear of intimacy, which obviously then can cause relationship problems, and then psychosexual problems can be really common as well. Obstetric complications are probably the best studied of the complications, and there's a huge variety. So long, slow, arrested or obstructed labors. So again, it is considered relatively common for the first child to potentially be stillborn. Difficult deliveries, increased episiotomies, increased tears, quite often really severe tears with a lot of bleeding from them. Impossible to provide intrapartum assessment, or very difficult, because the introitus may not have fully opened in order for that first pregnancy to occur. Higher cesarean section rates, higher hemorrhage rates, and maternal and perinatal mortality rates. So one very big study that was done on this by the WHO now almost about 17 years ago, looked at 30,000 women, and going through all of those things I've just said, they confirmed the C-section rate was increased by 30%, postpartum hemorrhage 70% higher, episiotomy rates increased. If those women were accessing hospital care, they were likely to stay longer. Their infants were more likely to require resuscitation, 2/3 more likely than anybody else. And perinatal mortality was significantly increased, as you would expect, mostly increased in the type 3 FGM. When you consider, I suppose, that an awful lot of the women won't even be represented in this because they don't actually have access to hospital care. They may be delivering their babies in remote rural areas. But then all of these complications may in fact be even more significant than this. So how might this present to somebody's medical practice? So, I mean, it is possible that somebody will come in and request an examination for FGM, or say that, they've had FGM and they need something done because they're not able to have sex, or because they're going to be getting married soon, or because of fertility issues, and that they need deinfibulation. So deinfibulation is opening up of a closed vaginal opening. But a lot of research has shown that mostly women will not volunteer this information, but at the same time are sort of waiting to be asked. So there's a lot of studies that show that women are hoping that a healthcare professional will bring the subject up first, so that they can then open up about it, but just don't have the ability to volunteer the information. So it's really good to know that, and know that people are open to talking about it if you bring it up. In the UK, I just mentioned this because this is a country where they have had FGM legislation for 30 years. They've had migrant populations from these countries for longer than that, and they have dedicated services for FGM for a long time, and still 90% of all cases present during pregnancy. And then to come to the cervical screening issue. Cervical screening is both a possible problem with FGM, but also it can be looked on as an opportunity to bring up the subject. So to first of all, I suppose, consider just broadly the context and whether or not, how to bring up the subject of cervical screening to somebody who might have had FGM. I think the first thing to kind of think about is just the fact that newly arrived migrant women who may never have had cervical screening before, so they really are a population that we want to get involved in screening, but they're completely unaware of how our health system works. They maybe are from countries themselves that have either very poor health infrastructure because of conflict or poverty, or they themselves were from very remote parts of those countries where they didn't really have access to healthcare. So when you're looking at a population like that, a concept like health screening can be actually a really, really difficult one to explain. So as a kind of a first step, you know, even though I would be having consultations with women using interpreters, I still find it quite difficult to fully explain the whole concept of cervical screening in this way. And I do use the videos that have been developed, you know, that actually go through it. It's each one is somebody, and there is one in Somali, which would be a huge number of these women, where they actually explain what cervical screening is and what it's all about, what's involved in it. So I think that's actually a really useful resource to have. So that's the link there, and then you can choose whichever language that you might need. And that's kind of sometimes maybe at the very first visit, rather than actually trying to get on with doing the screening, just to actually get them to review the video and make another appointment for them to come back with questions then. So then if you have an invitation, if you're considering inviting somebody to screening and maybe they viewed the video, then you need to consider if FGM might be an issue. So let's say you know that the person has come from Somalia. You could say, for example, in Somalia, many women have had cutting or circumcision when they were children. Do you think this happened to you? Do you know if this happened to you? And in general, once you've brought it up like that in a non-judgmental way, the women will be very forthcoming and say yes. The other thing, I suppose, is trying to assess whether women have ever been sexually active before you're going to consider whether or not they should have screening. And it may well be that if you ask that question, just have you ever had sex, they're going to say no. But I suppose that's just, you need to be aware of taboos. So it would be very difficult for them to admit to having had sex if they're not married. But also they may not consider that they would say yes if the only sex they have had has been a sexual violence incident. So whereas if you ask directly if they were raped or forced to have sex, then they might actually tell you the answer to that. And again, I think it's really important in all of these contexts that if you need to use a translator, it needs to be a professional translating service rather than potentially a friend or a family member. If a woman has had FGM, she may well be reluctant to have screening, either because she just assumes that anything that touches that area is going to be really painful, or even if she has had sex and knows that it's not painful, she may simply be afraid because she's not sure that, you know, to us, how abnormal is this going to look? So she's afraid of somebody saying something about what she looks like. So you want to kind of get, if somebody says yes, they think they have had FGM, then you need to try to get a little bit of history. So if they do remember it, which they may not because they may have been very young children at the time, just a brief history of what happened. And that's really, I suppose, only if they are willing to tell you, first of all, but also because it's going to give you an idea as to how traumatic that experience was. It's often remembered very clearly as a very traumatic experience, mostly described in relation to terrible pain. You know, a lot of people have said to me, pain, I will never forget that pain. They talk about pain, trying to pass urine afterwards, about, you know, trying to be made pee when they felt like they really, really didn't want to. Being held down, you know, really, really strong memories about being held down. Quite often their legs are tied together afterwards so that they won't burst stitches. They may talk a lot about bleeding. And of course, they may have not even had any kind of worrying bleeding, but it's going to seem like a lot to them, and there's going to be a lot of trauma associated with that. They may refer to other girls who had FGM at the same time, and again, that's somebody that, you know, either was really, really sick or that died. So when you think about all of this, and this is the very, very first time anybody has ever examined or touched their genitals, you can understand that it would be very difficult for somebody who's been through that experience to submit to any gynecological examination. So it's really important to try to enable the women in this situation to get some of that control back. This was something that was done to them. All of their control was taken away. So I think if you're going to do any examination, it's really important that you make sure they understand that no matter how close you are to being finished, if they say, I can't do any more, you're going to stop straight away. And that they know, and you say it to them several times, if you want me to stop, you just say stop, and then I stop. And obviously that you stick to that. Other relevant history, I suppose, would be, in relation to sexual history. So is this somebody who's actually been in a healthy sexual relationship in that, they're to have, comfortable sex without anxiety? Or is it someone who is in a relationship or was in a relationship where sex was always painful or was very painful for the first year or until they had the first baby? It may be somebody who tells you they're married, but is that, or were married, but was that marriage a forced marriage, which would be, again, really, really common. Or is there only sexual history relating to sexual assault or rape? And obviously, in somebody who has, if their only sexual history is related to sexual assault or rape, they still do require screening. They still would benefit from screening, but it may just take them a longer time to be able to do that. Obstetric history, so have they had children? And if they do have, if they say no, they have no children, just to make sure that that doesn't mean that they actually had a stillbirth. If they did have a delivery, was it C-section or vaginal delivery? If it was a vaginal delivery, did they have to have a lot of stitches? Did they, again, you need to think, well, they may, if they've had a vaginal delivery, that may mean that the FGM has been opened, but in fact, in some places, it could also have been reclosed. So you may still not be able to do a screen. So then if you're going to kind of proceed trying to take a sample, I suppose it would be good to at least say to them at the start, some women who've had FGM, taking a sample could be very painful. In some cases, we might not be able to do it. So I'm just going to do an examination first, if that's okay, just to have a look and see. And when you do that, then, if you're not going to be able to do the screen, to make sure that they understand that if we have to delay screening for a while, that this is not dangerous, that it's okay, that we can, arrange for them to have a procedure done, and then that they will be able to do their screening more easily. And again, if you're talking about referring them to have de-infibulation, which is opening of that FGM, to be understanding that they may not actually want to go ahead with this. It might not be acceptable for them if they're not married. Sometimes they will refuse it because they are afraid that if their asylum request is not granted and they get returned to their home country, that the FGM would be done again. Or just simply that even if they stay here, that if they want to marry within their community, that they would not be able to be married if their FGM has been opened. You can refer directly to our clinic in the IFPA if you don't feel confident about examining and assessing them yourself. Or you can do an examination, and even if you're unsure whether or not it is something that requires treatment, you can refer for further assessment. But I suppose just if you are going to examine somebody, it's important that you're willing to explain the findings. So if you feel that you wouldn't be in a position to do that, then it's probably better just to refer them. So the people that you definitely should not be taking a sample from, any type 3 FGM that has not been opened, you shouldn't even be attempting it, but I don't think you would once you would look. The other thing, I suppose, is to just kind of look and think, is there a lot of, okay, maybe there is an opening there that you could pass a speculum into, but if that tissue all around it, that scar tissue is extremely tight, you might be able to pass a speculum, but you may not be able to open it sufficiently. So, you would really have to talk to them about that and see whether or not they wanted you to try. And then any woman that just appears too anxious about it, again, we would have a counsellor in our service who would be, like, quite often, say, women who are going to consider surgery. She would do 2 or 3 sessions with them, and it's really about kind of managing their anxiety and, you know, preparing for having something that they are afraid of. So you could consider referring for something like that and then try again in a few months. So then if you're actually taking a sample, so if the opening is normal size and there's no very tight tissue, it should be possible to take the sample as for any other woman, but just be aware that even though it may look fine, you might actually find that there's vaginismus on attempting to pass the speculum, and just to stop if that happens. And continuously remind the woman, as I said before, that they can say stop at any time and that they are in control of this. If you do need a translator, you make sure that you keep them on the phone, or if they're an in-person translator, behind a screen throughout, so that the woman feels that they have somebody that will be able to tell you quickly when they want you to stop. And then if for any reason you felt there was going to be any other samples needed, like if this was someone that you had been considering an STI screen or a high vaginal swab, just to try to make sure that you consent for doing all of those things at the same time, so that they don't have to have a second examination done. So if somebody then books an appointment because they've just got a letter from Cervical Check and they're booked with you, even though they're not normally your patient, or you have never seen them in relation to any kind of gynae issues before, so you don't have that history, you need to kind of consider when you're talking to people whether or not there might be that possibility. If you do, and you just ask straight away about country of birth and whether or not they might have a history of FGM, that's one way of actually avoiding, I suppose, a situation where you suddenly find out something only when you're examining. And just remember, as I said before, that just because somebody has had a vaginal delivery doesn't mean that it's going to be possible to do the sample. And then apart from that, even if somebody has a baby, they may have actually had an obstructed labor, had a cesarean section, and so the FGM never got opened. And that can actually even happen women who have given birth in Irish hospitals, and I have actually seen that at least once. So then I suppose the other thing, just to kind of make it less likely that you're going to end up in a situation that's really, really difficult, is just to get into the habit of very briefly having a look at the external genitalia before you try to pass the speculum. So if you already see that the clitoris or the labia seem to be absent, then maybe stop at that stage and just ask some questions before you go any further. And you have to be really careful about how you react and what language you use. So just be factual. Avoid terms that would imply any judgment about it. If there's an obvious reduction of the size of the introitus or a lot of scar tissue around it, you should just stop and say that you're not going to be able to do the test today. And if you have to stop, make sure when you're talking to someone that you've asked them to sit up, cover up, before you start discussing this, because otherwise they're really in a position where they're not going to be able to take in what you're telling them. If they're not going to be doing the test, let the woman get completely dressed and sit back down beside you before you start the discussion. And then the last kind of thing, I suppose, would be women who are constantly declining invitations. So you've mentioned it several times to them that they're eligible, you know they have children, so you know they're sexually active or have been, and they, every time you bring up cervical screening, they say, oh, not today, not today. So just consider if maybe one of those reasons might be fears regarding having had FGM. So if you ask again directly, you know, and it shows, I suppose, some reassurance to them, because it shows them that you know about FGM and that you know that it might make it difficult for them to have a test, and you're only going to go ahead if they consent and if everything is possible to do it. So just, I suppose, last kind of thing here just is about looking on this as an opportunity rather than a huge obstacle. Obviously, it can be an obstacle, but one that can be overcome. But it is an opportunity to bring up questions about FGM, because it's an appropriate time. You know, somebody isn't coming about a sore throat and being asked about FGM. They're coming in, or you're raising the subject of the fact that they should be having cervical screening. So it's reasonable in that context, certainly, to ask about FGM directly. And it's really important to detect it for many reasons. So, I mean, apart from doing the cervical screening, You're getting a chance to arrange interventions for that woman that could improve her quality of life, reduce ill health from complications of FGM, improve her sexual health, her sexual enjoyment, reduce the risks of serious obstetric complications in the future. It might, you know, cast a light on other health issues she has had that you didn't realize before, like recurrent UTIs. And then, of course, it's really important from a child protection point of view, because if this woman has had FGM and she has female children, they may actually be at risk of having FGM also. So I'm just going to end by just saying just a few really quick words about our service, which has been in operation since 2014. It is free for women to attend. They can either self-refer or be referred by GPs, practice nurses, social workers, hospitals, anywhere really. The number of women we saw in the first few years was actually very, very small, but there's been a really sharp rise since 2021, and this seems to be linked to a really sharp rise in inward migration from Somalia in particular. We have 2 doctors and 1 specialist counsellor, and our specialist counsellor is amazing, you know, because a lot of these women have a huge amount of trauma in their life experience, but also she's a psychosexual counsellor, so that's actually really, really helpful. Like in the beginning, we saw everybody within a week or 2 weeks of calling, whereas now we're looking at a long waiting list and trying to get additional funding to try to get through that list a little bit quicker. We use a professional interpreting service, usually a phone service, but sometimes in person if that's what the person needs. And we established a direct pathway with Professor Maeve Ogan in the Rotunda for women who required either deinfibulation or any kind of other vulval kind of issues to be looked at. And we have a part-time advocacy officer who kind of coordinates elements of the service like outreach or where we have to kind of liaise with other organizations. Our aims in general are it's very woman-centered. We want to find out what the woman wants from coming to the service. We will listen to her story if she wants to share it, and the examination and everything is done with consent and consent and consent all the time, reiterated. We document the findings and explain them. And if there are findings that you can't be sure about, you have to be honest and say, you know, I can't say, for example, if the labia have been interfered with because you've now had 3 children and women's labia can change over time. We would then just provide the onward referrals, either gynecology or counselling would be mainly the ones. Look and specifically ask about where there may be child protection concerns. We would kind of try to be holistic in terms of going through whether somebody might need STI screening, contraception, cervical screening, and that quite often might need a 2nd or even 3rd visit because sometimes the information at one visit can be just overwhelming. And then most of the women also require a letter of support for their application for asylum or international protection. So the Istanbul Convention on Sexual or Domestic Violence to Women is the kind of criteria under which we write those letters. And just then in terms of women attending us, they have quite a lot of challenges at the moment, particularly recently arrived women. They're getting delays getting PPS numbers, GMS access, GPs, they may have little or no English and have had multiple levels of trauma. So FGM sometimes is way down their list in terms of the things they have experienced: sexual violence, you know, violent bereavement, loss of family members through murder, conflict, separation from family and friends, and then they have anxieties and fears relating to their accommodation. Quite often they're going to be in accommodation where they're sharing rooms with 2 or more people, sometimes up to 9 or 10 people that they don't know from before. They can have really, really unexpected and very rapid accommodation changes, which means that they no longer can get to the service. And then in some cases, we've had child protection concerns already where they're worried about a child being taken from the country for FGM at the time that they're presenting. So that's just really, I suppose, that's from our point of view. the first slide was from their point of view. So I suppose just in general, what we would now be trying to do, apart from working in the clinic itself, is a lot of interagency works to try to develop robust pathways for like child protection with TUSLA. We've had quite a lot of engagement with the Garda Síochána recently, which has been really helpful. And, you know, education for healthcare professionals as well. So key messages then, I suppose, be aware of this practice, be aware of the really high prevalence countries, be prepared to ask women where they were born, and also I suppose to consider from the child protection point of view, where was their partner born, because that could actually be something that then the children could be at risk even if the woman isn't from an FGM practicing country. And then consider it where you've got possible symptoms that could be related to complications like UTIs. Be aware that it could arise in relation to cervical screening and kind of think about how you're going to approach it. And whereas obviously there should be cultural sensitivity and, you know, non-stigmatizing language, but it should also be very frank and clear discussions. And then in relation to kind of pregnant women that have FGM, it's really important in hospitals that the maternity record is used to document that. But also if you're referring for antenatal care, that it's really, really essential that the obstetric team will be aware of the FGM. And then the other issue is obviously looking for children who may be at risk and be prepared to act on child protection issues. Sorry, that's just our contact details, so anybody can contact us through those numbers or by emailing. The woman, as I said, can book directly, but if that's difficult for them because of English, we have no problem whatsoever with anybody else booking. And if somebody else is, just to let us know if they need an interpreter. And I'm absolutely willing to take calls from people, you know, generally might not be able to talk to someone immediately, obviously, if I have a clinic myself, but to actually get back to people who have queries or want to ask about any cases that they may have encountered themselves. And those are just some resources that actually give quite good information. The FGM information for healthcare professionals working in Ireland, the Akitwa one has been updated recently. That's actually a really good one for Ireland. But all of those are all up-to-date resources. So that's it. Thank you very much.